Hello, and welcome back to the fourth and last section of the INTREC lecture on education, socioeconomic status, and health. In this section, we're going to talk about basically research approaches to understanding socioeconomic influences on health. We'll talk about observational designs and causal inference challenges and other research designs. I'm going to start off by giving a framework for thinking about causal inference. Because it's helpful to have that in the back of your mind when you're actually thinking about how do I specify an analytic plan. So here's a sort of common, there's a huge philosophical tradition on causal inference, but here's a very common and to me very helpful framework. Very commonly, we would like to know about causal relations. We want to know if we intervene to change this exposure, would this outcome also change? But we can't observe that. We actually don't get to change X because it's too expensive or it's unethical or we just don't have access. So we can't actually directly address the question we care the most about. But we observe statistical associations. We see that people who happen to have high values of the variable X also happen to have high values of the variable Y. So we're trying to go from the statistical associations back to understanding the causal relations. Why do we care so much about whether something's causal versus whether it's just a statistical association? The reason that we care so much about whether something's causal is that's what tells us how to translate our evidence into public health interventions. What kinds of things we can do that actually could improve people's health. Not just describing inequalities, but actually saying, if we change this, we can improve population health. So why study statistical associations? Well, we study statistical associations, first of all, for surveillance. It's a very important task of public health is to understand how social patterns change and so forth. Next, for insurance and prediction. So if your task is to make a decision about who to insure or who to not insure, how much money somebody will cost if you provide an insurance, then you need a statistical association, and you don't necessarily care about causal questions. If you are a physician and you're trying to figure out who should I provide care, who is at most risk of having a bad outcome, which group out of this 100 people, who do I think is going to have a heart attack in the next 2 years, that is a statistical question. You're trying to predict who is at risk. It's very useful to understand that, but it's not necessarily a causal question. And the third, and to me most important reason to study statistical associations is that it's statistical associations that help you draw causal inferences, and it's causal inferences that tell you what you can change to improve population health. So how do we make causal inferences from statistical associations? Well, essentially what we're always doing is we're trying to find two groups of people, and we say, here's a group of people who are exposed, and here's a group of people who didn't have that exposure. So this is a group of people with low education, and here's a group of people with high education. And we're going to compare their health outcomes. We're going to compare their diabetes status. And we would like it to choose these two groups such that the high education group has the diabetes status that the low education group would have had if they'd had high education. So we're trying to find one group to stand in for the outcomes of the other group. And this is a quote from Maldonado and Greenland, and they say, confounding is present if our substitute imperfectly represents what our target would have been like under the counterfactual condition. The counterfactual condition being, instead of giving this group low education, what if we'd given them high education? So for any analysis, you can ask, what is the identifying contrast? Which two groups of people am I actually using to represent each other's outcomes? And what causal structures could have generated the statistical associations we observe? We're interested in knowing whether X caused Y. What are the range of causal structures consistent with the observed statistical associations? I'm going to talk about two general approaches to demonstrating that some exposure causes an outcome. I think that many of the statistical techniques that we'll talk about, regression and so forth, can be categorized can be applied under each of these two general categories. One approach is to condition on all of the common prior causes. So if we see that X and Y are statistically associated, one possible explanation is that X causes Y. Another possible explanation is that Y causes X. But a third possible explanation, which is really what we're trying to get at, is that there's something else that we didn't observe that influences both. And that means that in that case, if there's some other factor, some U that influences both exposure and outcome, we call that confounding. And what it will mean is that X and Y will be statistically associated even if X doesn't affect Y. That basically the outcomes on Y for people who are exposed to X do not represent the outcomes on Y people who are not exposed to X would have had they been exposed. The people are not exchangeable. So that's one category. And when we undertake multiple regression adjustment, propensity score modeling, covariate matching, covariate stratification, these are all tools that are essentially efforts to condition on all of the common prior causes. A second category of sort of approach to causal inference is to use what's called an instrumental variable. And this term instrumental variable is a very old term. It's been used for decades in economics. There are some special cases of instrumental variables, but the key feature of an instrumental variable is it is some source of variation in exposure that has no other reason it would be associated with the outcome. So it's something that wiggles exposure. So in this case, the variable Z is the instrumental variable. So it's something that wiggles exposure, but there's no other reason it would influence health. And if you have an instrumental variable, you actually can test whether or not X affects Y, even if there's a bunch of unmeasured stuff that influences both and you don't know anything about it. So in situations when you don't think you can plausibly condition on all common prior causes, then it's great to go to an instrumental variable approach. So instrumental variables are randomized controlled trials, or special cases of instrumental variables, and natural or quasi-experiments are also instrumental variable approaches. The majority of research on socioeconomic status and health is observational, and in this, in that it's using the analysis, that approach to causal testing for causality is based on conditioning on all common prior causes. So almost all of the research that you see is essentially taking the first approach of trying to control for all the factors that might influence both socioeconomic status and health. What is the critical assumption in this kind of research? The critical assumption is that health outcomes of people with high socioeconomic status are the same as the people with low socioeconomic status would have had if they had been given high SES. I'm going to walk through that again because it's really important. If you're doing observational research and you're trying to condition on all common prior causes, control for confounders, and kind of our typical regression adjustment, the critical assumption is that health outcomes of people with high SES are the same as the people with low SES would have had if they had been given high SES, and vice versa. If there are factors that influence both SES and health that you have not controlled for, then this assumption is not met. So you have to think about what could influence both my SES measure and my outcome that might be biasing this. So let's think about that. What are plausible factors that influence both education and health, adult health, but are hard to adjust for? Now I want to stop and suggest that you write down possible factors that you think might influence both education and adult health. By education here, we'll focus on childhood education, so completion of primary school, for example, and adult health, say development of diabetes or development of stroke. So stop now and think for a couple of minutes about possible factors. How are we doing on time?
8 minutes. 9 actually.
Okay, we're good. So here are some examples of things that I think are important possible confounders. Number one is parental socioeconomic status. So as we discussed, your parents' SES influences how much education and the quality of education, and very likely influences adult health outcomes. So that's one possible confounder. Now we might be able to control for that, but it's often hard to measure and many data sets don't include it. So that's a concern. Another is early life health. So when we study older people, we very rarely have good measures of how healthy they were in childhood. Now their later life health is not so important because that's a consequence of education, right? They probably completed their primary education in childhood, and so their adult health is potentially a mediator but not a confounder. Whereas early life health, their health as a baby, that may be a confounder. Genetic information is often hypothesized to influence both socioeconomic status, educational attainment, for example, and diseases. Place of residence. Certainly your access to education and high quality education is in part influenced by where you live. Personality features, determination, tenacity, these are factors that might influence both educational attainment and health. And cognitive skills. We can think of cognitive skills are certainly influenced by education, but you might hypothesize that cognitive skills also affect how much education you get, so that it's on both sides of that pathway. Cognitive skills at different life course points. And these are factors that, for the most part, we have very little measurement of in most studies. And so there are concerns about unmeasured confounders for evidence on socioeconomic status and health and education and health. I want to just spend 1 minute talking about genetics, because for a long time this was a major concern, I think. And current research isn't really supporting the idea that there are very strong genetic predictors of education. So there's a recent paper that actually did identify 3 specific genetic polymorphisms that were associated with education. But when you put all of the information on these 3 genes together, it accounted for only a tiny fraction of the variance in education, only 2% of the variance in education. So in fact, the influence of genes was very small, and there's no particular reason to think that those same genes influence any particular health outcome. So directly influence any particular health outcome. So it's not clear that genetics is a really important confounder of my list. I put it on there because it's worth thinking about, but it's not, at this point, the evidence is not so strong. It should be noted that we're still in early days of this kind of research. Maybe we'll find more. In closing in the discussion of observational data, I just want to make a few suggestions when you're thinking about how to design a study of your analysis of observational data on the effects of socioeconomic status on health. One is to start off by saying, if I was going to design a trial, what would that trial look like? Like, how could I design that trial? Even if you could never conduct the trial, it's completely hypothetical. Just start off by saying, what would you actually do? Who would you recruit to the trial? Would you want everyone in a community to participate? Would it only be people from certain socioeconomic status, like poor families? Would it only be people who are at high risk of a disease? Who would you want in your trial? What specific conditions would you deliver to would you randomize the treatment and control group to? Would you randomize them to primary school, to a high quality primary school, low quality primary school versus no school? What exactly would be the treatments? What outcome would you measure, and why do you expect it to change? A really critical question is, how long do you think it's going to take for the treatment that you're considering, the exposure you're considering, to potentially influence the outcome that you're looking at? So if you think, if you're interested in the effects of education and you're looking early in life, you're not very likely to be able to see associations between education and lung cancer in young adults because there hasn't been time for the disease to develop yet. Whereas if you're looking at smoking, you might be able to see effects of education on smoking because smoking, education influences smoking in the short term, at least in adolescence. And similarly, MI, the timeline might be somewhat different. So it's important to think about what is the etiologic period that could potentially link the socioeconomic variable to the health outcome. And one way to get yourself to think about that is to try to design a trial and think about how long would you have to follow people to actually see this. Additionally, it's really valuable to just draw a causal diagram showing how you think the exposure and the outcome relate. What are the mechanisms and what are the possible common causes of the exposure and the outcome? And then make a list of variables that you want to adjust for. Don't adjust for variables that are affected by the exposure. So if education affects, for example, if you're interested in the effects of education on stroke, you don't particularly want to adjust for self-rated health at age 60 because self-rated health at age 60 is probably affected by education. There is an exception to that, which is when you're interested in mediation analyses. And don't adjust for variables that are affected by the outcome. So if you're interested in the effects of education on stroke, don't adjust for factors that you measured after onset of stroke. Don't adjust for anything that could have been influenced by having a stroke or not having a stroke. I want to close by just mentioning that there's now, despite a long history of questions about the causal effects of socioeconomic status on health, there's now an increasingly strong evidence base from the other type of causal inference approach, which is randomized trials or natural experiments, i.e. instrumental variables. Formal randomization, in which you do a randomized controlled trial, is the most rigorous approach to evaluating causality. It may not be feasible ethically or logistically, but now we do have some randomized trials suggesting health benefits of socioeconomic status improvements of either, for example, monetary payouts or other kinds of improvements. One major question in understanding randomized trials is to ask whether or not these results are generalizable to other populations, communities, or to slight variations in the intervention. And at this point, we've had a very hard time establishing when results are generalizable and when they aren't. And it's because it's so difficult to conduct formal randomized controlled trials, it's very valuable to look at natural experiments. It's just hard to think of compelling natural experiments for socioeconomic status. So a natural experiment is when exposure is to the treatment, for example, education or income, is due to an external event that, for example, has nothing to do with personal preferences. There's no other reason it should have correlated with your outcome, for example. Some examples of really influential natural experiments related to education, for example, include changes in mandatory schooling laws. So most places have some rules about how much education children should pursue, and changes in those laws provide fantastic natural experiments. Building schools or improving school facilities in regions can also provide natural experiments. Unexpected introduction of universal pension guarantees. This has been a very influential and powerful natural experiment for the provision of the health effects of provision of extra money to an older individual in a family. Changes in social insurance benefits, other kinds of changes, many policy changes. These are very powerful potential natural experiments. To come up with these examples, you have to think about what are the factors that influence your exposure. If you're interested in estimating the effects of education, what actually determines someone's access to education in the environment or community where you're studying this process. And then you can think about which of these things seemed essentially random or pseudo-random, and were not influenced by whether or not somebody wanted to pursue more education or less. That concludes our lecture on socioeconomic status, education, and health. Thank you very much.